Yeah, so I'm going to talk about atypical manifestations of diabetic retinopathy, a disease that we all facing, and it's exploding. We have no financial interest to declare. So as the world witnesses a rampant and massive increase in the incidence as well as prevalence of diabetes, the unusual cases of diabetic retinopathy being seen more commonly in all of us, and not just retina specialists. And very often it is this recognition of these unusual features which is the first and often very often the most important step in their management. So this atypical behavior is demonstrated by the inherent variability in diabetic retinopathy itself per se, the various systemic as well as ocular diseases that affect the course of diabetic retinopathy, and other miscellaneous features. How is inherent variability of diabetic retinopathy manifest? It comes through either diabetic disc edemas, a featureless retina, we'll talk about this, peripheral abnormalities, we think it's a central disease, but there are situations where the periphery is also involved, unusual courses that diabetic retinopathy can take, tractional diabetic papillopathy is something we'll look at, and other few miscellaneous things like foveal new vessels and huge, large cortical spots. So what is diabetic papillopathy? It's been described as a transient bilateral edema, usually seen in young patients, usually associated with good visual acuity and minimal background diabetic retinopathy changes. And this has been described as to happen because of the extension of the microangiopathy of diabetic retinopathy onto the optic nerve head. A close differential for this, something that you have to keep in mind, is raised intracranial tension, hypertensive retinopathy, new vessels of the disc. As you see here, the first two slides on the top, papilledema, the close differential. You have to look for signs of raised intracranial pressure. Neuroimaging is a must to rule this out. New vessels of the disc can coexist with diabetic papillopathy also, it's very rare. But new vessels of the disc, obviously, the haphazard orientation, it spills over the disc margin, it gets elevated, and then angiography will show it out as a leaking lesion. Whereas with diabetic papillopathy, the vessels are usually radial and within the substance of the disc. Grade 4 hypertensive retinopathy, a simple BP assessment would rule this out. The disc would have splinter hemorrhages around, you would usually have macular star or fan. So there's always this debate about diabetic papillopathy versus anterior ischemic optic neuropathy, and this was highlighted by Vakietz in his article in Survey 2002. NAION or non-arthritic AION is the commonest cause of disc edema in old people, in both the diabetic as well as the non-diabetic populations. That has to be in both diabetic and non-diabetic. And differentiated from diabetic papillopathy, NAION is associated with greater visual loss, deeper visual field defects, relative afferent pupillary defects, sectoral hypoperfusion on fluorescein angiogram, and a poorer outcome on follow-up compared to diabetic papillopathy. And many people have said that there is an overlap in the spectrum of two diseases, as Vakietz also postulated. But then Hayre, as you probably would have heard, is a great arguer against the existence of diabetic papillopathy, and he says it's nothing but NAION incipient. So this is AION on top. You can see on the left, the right eye is a crowd. You can see a typical crowded disc, and on the left eye, the edematous AION disc. As a close differential is diabetic papillopathy, which can look very similar. Diabetic papillopathy, interestingly, can resolve spontaneously. It has a good natural history, and with just good control of diabetes, there's a patient who just resolved spontaneously. The suffused edematous disc resolved, and you can see that on the angiogram also. Featureless retina, described in Ryan, is basically proliferative diabetic retinopathy masquerading as mild non-proliferative diabetic retinopathy. Highlight is extensive capillary closure. No cortical spots, ilmas, blot hemorrhages are usually seen, and this is because it's been postulated that in cases of extensive capillary closure, these ilmas, blot hemorrhages, dot hemorrhages all tend to disappear. And cortical spots, as we know, are ephemeral, they do go off. What one needs to look for are these white thread-like arterioles, which you will see alongside, close to the disc very often. In angiography, you will see extensive deep capillary non-perfusion and new vessels. So this, to the casual eye, may look like a picture, and this picture may give you the appearance of mild or moderate non-proliferative diabetic retinopathy. But if you look very carefully, as this arrow highlights, there are those white thread-like arterioles emanating from the disc. And when you do the angiogram, you're surprised very often that this is actually a case of a high-risk failure. You can see the extensive capillary dropout and the knee vessels of the disc. Peripheral diabetic retinopathy, as I mentioned, this can occur in 2 to 3% of the cases. So you have to keep that in mind that this can also happen. So it's not. So if you're looking at a diabetic patient, we tend to do just a stereoscopic 90D examination. Very often we should tend to look beyond. Okay, especially if it's a chronic diabetic. So Nikki et al. Showed that this was there in 2 to 3% of cases. Equatorial fibrovascular proliferation moving on to peripheral tractional detachments. Most of the tractional detachments are either macular or just extramacular in diabetes, but you can have peripheral tractional detachments also, as was documented by Han et al. Oral fibrovascular ridges have been seen in 50% of cases of peripheral PDR by Terasaki, and Ishibashi even documented direct choriovitrial neovascularization. So all these things can happen. Again, to the casual eye, this might look like a case of moderate NPDR if you look at it. But a complete panoramic pan-retinal examination would shows this to be a case of peripheral PDR. So that's why it's important to not just look at the macula and just the surrounding area, but to look all around. Sometimes you might find thin, faint new vessels deep into the periphery too. Diabetic retinopathy, as I mentioned, can take an unusual course too. Florid diabetic retinopathy was documented by Beaumont and Faber. This is a rapidly progressive, very severe PDR, and usually uncontrolled type 1 diabetics. When you have uncontrolled type 1 diabetics, presume that he will, if he remains that way, move very fast. And these cases should behoove you to issue extensive, aggressive, early pan-retinal photocoagulation when required if there is traction detachment or hemorrhage, early vitrectomy. Spontaneous regression, on the other hand, of diabetic retinopathy has also been seen, as documented by Bandilo et al. And Hijero, where he found 3 type 1 diabetic women with stable blood sugars having surprisingly reperfusion of the CNP areas because of the sudden repair of the blood retinal barrier. So this can happen, but it's very rare, and it's not something you should wait for. Few curio pieces. Foveal new vessels were noted by Finkelstein and Jundev, new vessels occurring at the perifoveal ring. And this tended to happen in patients who had long-standing insulin-dependent diabetes mellitus and proliferative diabetic retinopathy. And these patients invariably have new vessels in the periphery also. And these new vessels, surprisingly, in these articles, these new vessels tended to be stable. They didn't immediately break and bleed, as reported by these people. Huge corneal spots are also seen. They're used to a size of about a quarter disc diameter. But 2 to 4 disc diameter size, huge, large corneal spots have also been reported, and in some cases they've been confused with medullated nerve fibers. But this has been seen, and typically you have stenosed arterioles, as reported by Egger et al. At the margin of these corneal spots, and you find these little an attempted reperfusion at the margin of this with these collaterals coming up. Tractional diabetic papillopathy was a term that Peter Kroll put out in BJO 99. He described vitreoretinal traction, which we think usually happens or should happen at the macula, but taking a toll on the optic disc or the optic nerve head and causing pallor and a reversible, that's interesting, it's a reversible visual loss. Let me show you an interesting case. This is a case, patient came in with symptomatic, with right eye best corrected visual acuity 6 eye, and the other eye you see moderate changes only. And this very florid picture in the right eye. A lot of hemorrhages, and first appearances even looks like one could confuse it with the CR view. But you see these 3 hemorrhages and stuff, and it is very, very florid, and you think it's a massive neovascular process. But when you do the angiogram, you're surprised. You'd expect a massive leak right at the disc, but no, there's not that much leak. There's some amount of leak, but not so much. When you look at the OCT, you find some level of incipient traction. Look at the tissue around the disc, and not just around the disc, surrounding the disc too. It's slightly elevated, slightly lifted. So at this point, we just observed this patient vision was good. We didn't think there was any grounds. Within 3 weeks, this patient came back, and vision had dropped rapidly from 6.9 to 6.36. And you can see now this patient started bleeding. Look at the way the hemorrhages are, oriented. It's all going as if somebody's picked up an umbrella or a tent right in the middle over the disc, and it's all streaking out like that. And that was, we don't have a stereoscopic view, but that's how it is. But what's most interesting was the OCT, which showed this massive traction over the disc, pulling up the disc tissue, and that had actually led to this symptom. So what we realized that this is a case of tractional papillopathy, and the hemorrhages were the breakthrough hemorrhages from the small vessels. So immediately advised and went ahead with the vitrectomy, and the patient post-vitrectomy improved 6x in dramatic resolution of the florid picture of the fundus. And you can see the macular contour also has come back, and the traction of the disc. That's a small stump over there that we left behind. Now, systemic diseases, as we've seen, can affect diabetic retinopathy. These diseases which affect the diabetic fundus in a typical manner: hyperlipidemia, carotid occlusive disease. Lipemic retinopathy, as described by Brown et al., basically has high serum lipids, usually triglycerides, seen in 2% of cases. It's a minor variant of lipemia retinalis. There's a typical Coates-like response. It looks like Coates disease, and as Gupta et al. Have shown us, statins can reduce retinal exudates and have an ameliorative effect. It's a case of lipemic retinopathy. Carotid occlusive disease can induce what is known as asymmetric retinopathy. So it is believed initially by Gay, Rosenbaum, and Moss et al. That it slows down or retards the progression. It's actually good for diabetic retinopathy. But that's counterintuitive logic, and most people, and now the current thinking is that it actually worsens diabetic retinopathy because of inducing extra ischemia. And the hallmark pathology is this ischemia, and when the carotid is occluded to the extent of 90% or beyond, it can even, as we all know, induce ocular ischemic syndrome. This is a classic example of an asymmetric diabetic retinopathy where you have a very vicious fractional detachment in the posterior pole and moderate changes in the left eye. So, ocular diseases, as I mentioned, can also affect diabetic retinopathy. These are some ocular diseases which retard or slow down the progress of diabetic retinopathy: myopia, glaucoma, optic atrophy, extensive choroidal scarring, retinitis pigmentosa, and posterior vitreous detachment. How do they do so? So myopia, glaucoma, and optic atrophy do so by decreasing the oxygen demand and decreasing the VEGF release. Extensive choroidal scarring and retinitis pigmentosa does so by destroying the oxygen-hungry photoreceptors. And PVD, posterior vitreous detachment, removes the scaffold for new vessel growth. Some diseases which alter the picture of diabetic retinopathy: radiation retinopathy and parafoveal telangiectasia. Radiation retinopathy, by virtue of the microangiopathy and the occlusive microangiopathy that is induced by the radiation, the deleterious effects of radiation, can complicate diabetic retinopathy and accelerate it, cause hemorrhage. Parafoveal telangiectasia is common differential diagnosis. You can see this happens in patients with diabetes, but is not part of the spectrum of diabetic retinopathy, especially the type 2A. So what does one look for in asymmetric diabetic retinopathy? Dr. et al. Stated that by definition it's proliferative diabetic retinopathy in one eye and non-proliferative diabetic retinopathy in the other eye, and stable thus for about 2 years. One needs to rule out the ocular factors that I mentioned. One needs to look for featureless retina, peripheral PDR, and carotid insufficiency. And then once we rule all these out, rarely there is this natural asymmetry which can happen in 5 to 10% of cases. So in 5 to 10% of patients that you see also, you might find this kind of an asymmetry. This is, but again, a word of caution. Again, what looks to the casual eye as a case of asymmetric diabetic retinopathy, with the right eye having vitreous hemorrhage and the left eye again that looks like moderate NPDR. If you see that there is, when we do the angiogram, the left eye also has PDR. So don't jump in and label things as asymmetric. Try to look very carefully for changes of proliferative diabetic retinopathy. If you have any suspicion, don't desist from doing an angiogram. So in summary, it is this recognition of these unusual features and atypical features which has helped us improve our diagnostic sensitivity, as in the case of featureless retina, helps throw new light on the pathogenesis, as in the case of retinitis pigmentosa, modify medical treatment in the case of lipemic diabetic retinopathy, and surgical treatment, as in the case of equatorial fibrovascular proliferation, doing a vitrectomy for these peripheral TRDs, avoiding unnecessary treatment as with papillopathy and parafoveal telangiectasia, and mandating us and behoving us to institute early aggressive treatment as with florid proliferative diabetic retinopathy. Thank you.